everyone. This is Susan Clinton, and we're here with Tough to Treat. This particular podcast that you're going to be listening to today is about a women's health issue with a lady who had a diastasis rectus abdominis, as well as pelvic floor heaviness. I look forward to your feedback. Thank you. Hi, everyone. Susan Clinton and my partner, Erica Melo. We're here with Tough to Treat.
How's it going?
I'm doing well. How are you?
I am good.
On your way to Germany.
I am. I know.
In a week. So
can't wait.
So anyway, let's see. Let's just dive right in. Yes?
Sure. Yeah, sounds good.
Okay. So the person that I wanted to talk about today is an absolute lovely lady that I had the privilege of meeting, and probably in which she considers one of the most horrific times of her life, bless her heart, around the birth of her son, which should have been a very joyous time. This person is a 31-year-old female, and she came to me 18 months after the birth of her son. She had a normal vaginal delivery without complications. The reason that she looked me up and found me was that she was seeking help and encouragement around diastasis rectus abdominis. That she self-diagnosed, read way too much on the internet about, as sometimes they do, and tried to do a couple of online programs and realized that she was actually starting to have worsening symptoms of pain around her belly, as well as some heaviness in her vaginal canal. So she returned to her midwife and was diagnosed with just a grade 1 prolapse, which, is not completely uncommon. We certainly don't like them to be there, but it's not completely uncommon. The good thing about the grade 1 prolapses is with the right exercise and changes, you can actually, support those very, very well and return to heavy lifting and everything without complicating it. So that was good. However, that particular diagnosis on top of her DRA kind of flipped her out. The midwife did not pay much attention to her discussion around her belly. She was more interested in what was going on with her pelvic floor and her pelvic organ prolapse at that point. But she did ask for physical therapy so she could, get started. So she really self-advocated for herself, which was great. So she walks into the door ready to go. I'm all in. I want to know everything that's happening.
How large was the DRA again?
Everybody talks about in the research that we should use calipers. Well, nobody has calipers in their clinic. Right. So for her, she had a three finger separation.
Okay.
And it was really quite the biggest thing about it is not really so much if the muscles come together or not. What I really focus on with the diastasis is how spongy and loose is the tissues when you activate the abdominal wall, because sometimes I think that when we activate the abdominal wall, we don't tension the connective tissue the way it's supposed to be tensioned, which tells me that the deeper muscles probably aren't online and working as well, and they're actually overusing their rectus abdominis to try to hold their abdominal wall together. And it's interesting because I know Diane Lee has come out with some interesting ultrasound studies with Paul Hodges looking at this specifically, and it really has lit off some chimes for me, because it's certainly the way I've always thought. It's like, well, the muscles are coming together. That's not the, it doesn't seem like that's the issue. Why is every time they stand up and move and do things, and particularly talk, laugh, and other things, why is this tissue so loose and goosey, and it's just not being tensioned? It's like bone that's not being tensioned. Bone is going to get thin if it's not under tension and stress. And I think connective tissue has to form the same way. You got to tension it in order to get it to start rebuilding.
I know I took a course with Paul Hodges probably a couple of years ago up in Toronto, in Oakville at Laurie McLaughlin's clinic, and he presented a lot of research on pelvic floor and diastasis and women's health, and it was really interesting. And now that I'm talking with you, I'm going to go back and look at the course notes, because it's really quite interesting. And I know Diane has done some work lately. She came out with I believe a guide of some sort recently as well. So
I think she has a book that she
correct.
But that she put together that I'm going to get my hands on and kind of comb through. But in my clinic, I'm a small practice. I don't have I could get calipers. They're just so inconvenient to use. Let me pull out my calipers. I've already got somebody on my, in my clinic room that's already scared to death about everything. She's like on the verge of tears. And I'm not going to pull out scary looking things.
Yep, totally.
Unfortunately, I don't have a Rusi. It's on my dream list. We'd
A
really like
Rusi. What's a Rusi?
Real-time ultrasound.
Got it.
So I'd love to have one to like actually view the muscles and see, the patterns of activation and things like that. I know I've seen them, and you can get them on YouTube, and you can look at all of them, which is just great stuff to really kind of help you understand what's happening. It also, in many cases, can help the patient understand what's happening, but I didn't have that. So I have my anatomy books and and my whiteboard, and we draw a lot of pictures and do a lot of things. The interesting thing was, in talking to her, I like to sit down and just visit, much like you do, Erica. I want to get the story. What is the story? I know we keep going back to that in this podcast over and over again, but I just think the story is so incredibly powerful.
Yep.
I just had her sit where she was comfortable. Her husband came and took their precious 18-month-old son out to go play, and so she could have peace and quiet and visit with me. And so the story was that she had a normal birth and delivery, and she felt like she never really had any incontinence following her pregnancy or during pregnancy. She had some back pain in pregnancy, but it wasn't anything that she needed to seek help for. She felt like as long as she could keep moving and doing things, she was fine. So she was, really kind of a very normal, healthy pregnancy and moved on. And so I just asked her, I said, well, what do you think happened? When did all of this become, problematic for you? Well, at 6 months, at her son's 6-month anniversary, not quite the birthday yet, she was holding him and walking and actually fell. And in order to protect him, she allowed herself to drop down onto her knee and fractured her left patella.
Oh, interesting.
Yeah, okay. Very interesting. This was not something I was expecting to be talking about with her.
Wow.
And so I said, well, tell me about that. Tell me how that, just let's go through that. And so she had a really hard time because, she was, obviously worried that she was going to, injure her son with the fall. And she had no idea that she had fractured her patella for a couple of days. It just hurt so bad. And finally, they went, because the swelling wasn't going away and it was getting more and more painful. So she went and got x-rayed, of course, and they, put her in a knee immobilizer. And basically that was it. And told her,
that was it.
come back in a few weeks, no physical therapy, nothing. So she started working, along the idea of, just walking with the immobilizer and getting in and out of bed. At the same time, she was, still playing around and starting to feel with her tummy and wondering kind of why she had this thing that was happening in her tummy. And I said, well, describe that. And she said, every time I lift my head up, it's like I have another baby in there that pokes out. So she's basically what she was describing, for those of you who are listening to this, is what we call doming. In other words, the tissue, the abdominal contents and everything just kind of tends to make the tissue dome, like you would think about, the steeple of a church coming through. So her muscles, maybe the rectus was, activating, but the other tissue, like I said, in between the linea alba and the tissue surrounding the linea alba was very loose, and so therefore things could push through as she started to, raise her head up or activate her abdominal wall. So that became very distressing to her, and she began to worry about that. She wasn't making much progress with her knee, so she ended up finally getting to physical therapy for her knee, which was a godsend. They did a fabulous job. And, as she was telling me, she was like, I have almost full range of motion of bending, I can walk, I can go up and down stairs, I can, squat down. I just don't do it very much. And I said, you don't do what very much? And she said, well, I only go upstairs when I have to. They have a 2-story home.
Oh, gosh.
I know, right?
Yeah.
You're starting to get the picture here.
Yeah.
I don't really squat much because I'm worried about the heaviness in my pelvic floor, and I never get on my hands and knees. And it's like, why? Okay, so tell me about that. So I wanted her to just kind of keep going a little bit. And I said, is that because of the knee pain? And she said, no, my knee doesn't hurt anymore. It's because if I bend over on my hands and knees, my internal organs are going to come through my
Oh boy.
abdominal wall.
Oh boy.
So now, we have, what do we have here? We've got this like really fear-based, talk
Right.
about
Oh
fear
my Lord.
avoidance,
Yes.
and it's not
Yes.
really due to pain. At this point in time, she said, I noticed that when I was doing other things. And so what I try to do, she would show me this kind of wild position that she would get into. She would bring her legs really far apart and bend down at her knees in a partial squat to kind of make up the bed.
But how does she pick up things off the floor?
She
How does
doesn't.
she pick up?
She
She
would like,
doesn't.
yeah, she would just gather them up in a certain way and bring them as close to her as she could. And then she would show me how she picks up her son. I said, well,
Yeah.
I gave her a pillow. I said, we'll look at your son when he comes back from the park with your husband later, but to just kind of show me what you do. And so she would gather the pillow up next to her, and she'd put the pillow in front of her body, like her belly. And then she'd bring her
Hmm.
other arm around underneath and literally hold her belly in while she stood up.
Oh my Lord.
So,
Wow.
and I said, well, what do you do tell me about cleaning the house. Tell me, what are you not doing in your life that you want to get back to doing? What's going on here? And she would even carry the vacuum cleaner up and down the stairs. She would
Wow.
bring her son down in the morning and leave him down there. She had all the things she needed for him downstairs. And then when her husband came home at night, he would take him upstairs.
Oh boy.
Yeah. And so, and she's a violin teacher. So she, her studio is downstairs.
Hmm.
So her son generally would nap in the room next door if she was practicing, or if she was teaching.
Hmm.
And so she could, manage everything that way. So she found a way to manage her life. And, she was quite a joyous person to be having so much fear about everything that was going on. And so she was so this had continued so when she fell at 6 months, this is about the time when she started noticing everything else. Now, I imagine the diastasis had been there. I don't think it just popped up at 6 months after, after having a baby. But you never know. Stranger things have happened. Or maybe her trunks, her musculoskeletal system ability to compensate for, some of the changes from pregnancy just finally caught up with her with the fall and, having to move her leg in a whole different way with a long lever arm and doing things just really different, really perhaps maybe made that DRA, pronounced it a lot more,
Right.
definitely a bit more significant.
It's interesting that she associated it with the fall,
Mm-hmm.
And then carrying her son. And then from then on in, she decided she was going to self-limit all of her activities. Did she put a belt on herself? Or she just held her tummy in every time she did this?
She just held her tummy in.
Oh, boy.
So the interesting thing about all of this is with all of her reading on the internet, she did find a couple of what I would consider really good programs. The issue is sometimes when people find programs on the internet is they're not really sure if they're doing things in a way that's helpful. And she was starting to have more and more symptoms as she was doing it. So she realized that maybe I should really get somebody to put their eyes on me to help me go through this. But, kind of getting back to her story, at the time that I'm seeing her, her baby is now 18 months old. So we've gone 12 months, a full year since the fall, the fractured patella, the discovery of her DRA, and her splinting and moving in these habits. So now what we have in front of me is this lovely, lovely woman who has just really acquired a really dominant posture. And me, I don't believe in bad posture. I believe we need all kinds of postures.
Right.
I think we need slouched postures. We need happy postures. We need all of them. But I worry when somebody is really kind of stuck in a movement pattern and they really are not getting themselves out of it. And one of the reasons that it worries me is that her son is bigger and stronger. She has a lot more to handle, and she's already fallen once. And I start worrying a little bit about a risk of fall for her as well, particularly if she doesn't have a lot of variance in her movement patterns. It's kind of like knocking the stiff thing over. It's easier to fall that way. So, just really getting her story and really getting her to tell me what she thinks is going on was vitally important. And when she talked about her internal organs coming through her abdominal wall, I felt horrible for her that she had painted this picture in her brain, because that would scare anybody. And it's really a very harsh untruth
Yeah.
what we know.
Right.
Unless that peritoneal cavity has been breached, it's really not going, things aren't
Right.
going to, so first thing I did with her was, before I even looked at her, before I even
Mm-hmm.
had her stand up and move, is I pulled out the anatomy books and I
Yep.
said, let's have a anatomy lesson on your internal
Yep.
organs.
Yep. Yep.
And let's talk about where they're suspended from. And so we did. We went through the idea of the mesenteric root and how it holds everything in,
Very
and
cool.
and the whole stuff. And we talked about the greater omentum and how it comes over. And there's that. So we've got this whole other layer before anything internal gets anywhere near that peritoneal wall. And I just wanted her to get a different picture in her brain. And
Mm-hmm.
I had her draw on the whiteboard. I said, so tell me where you think, I said, we just kind of drew her belly, and I said, I gave her the marker, and I said, show me where you think the problem is. And so she did. She drew the squiggly lines and, made, the colors on there and everything. And she goes, this is where the problem is. And if I don't pull this together the right way, everything's going to come out this way.
Mm-hmm.
So we kind of went through that. And so I took her picture and left it because it's important to her. That's what she really feels. And I said, but what if we put in some pieces that you don't know?
Yeah.
We added the deep musculature, and we added the back musculature, and we added the glutes, and a few other things, and talked about the diaphragm and some breath holding and the support features and how it all begins to work together.
Mm-hmm.
And then one of the things that I also do is it's a trick that Julie Weeb does in all of her courses, is the balloon.
Oh, I've seen that.
Yeah. So I always have a balloon around. So I grabbed the balloon and I showed her. I said, if we grab the top of the balloon and hold it really tight where her upper abs were really overworking, what happens to the rest of the balloon? And she could see that it would push out in the front and push out down below. And so she started to begin to understand that maybe it's not something pathologically wrong with tissues. Maybe this is a strategy I began to adopt that has given me this sensation of this extra pressure in the front of my belly as well as down into my pelvic floor.
Yeah.
So she could get a different picture.
Right. And how does she carry her son? In front or on the side, or did she say?
Yeah, exactly. So one of the things that I wanted to know was, tell me about your violin and show me your position with your violin. So her violin, obviously, for all violinists, is on the left side.
Her violin, right.
And, so she holds the violin, in that posture on the left side. And I said, show me how you carry your son.
Yeah, interesting.
So she put the picture, she pulled the pillow over to the right side. I'm sitting here showing you with all of my arms like everybody else can see. She pulled the pillow over to the right side, and she goes, I sit him on my right hip. So when I had her begin, and we talked about that a little bit. I said, do you always carry him on the same side? Yes. And I said, are you right-handed or left-handed? And she goes, it's interesting. People have asked me that. And she goes, I'm right-handed. Because sometimes people will choose to carry their baby on one side or the other so that their dominant hand can be free.
Right.
But in the days of cell phones and, chip cards, we don't need to write checks anymore. So we don't need to have all that fine motor activity as much as we used to. People can text with both hands. So I had her stand up at that point so I could kind of get a picture of what maybe, because I could see in sitting she was shifted, her trunk was shifted to the left. Her upper trunk, her thorax was shifted to the left slightly. And I thought, well, she's a violinist. It's like a tennis player. They're going to have, if they're dominant right hand, they're going to have a much larger right arm than a left arm. It's just the nature of the thing, and performing arts is no different. So I wasn't, when she was talking, I wasn't putting anything together, but then when she stood up, you could see that she really had a very good shift over to the left with her thorax, but it actually made it look more like her right-sided the right side of her pelvis was really actually deviant to the right. So what came first, the chicken or the egg? I have no idea. But there's the shelf that she carried her son on. Was that right hip over there? And it's interesting because the fractured patella was on the left. So she is on the side that she's actually shifted over to. Which was very interesting.
You almost wonder if since she was, since her body or the violin was in her left hand and she's sort of left-sided bias, that almost by default she would carry her son on the right side, just so brain equalizes out the center of, or the center of mass in some way, right?
It's always, I always find it very fascinating
Yeah.
when I ask people to move, because
Yeah.
I sit there and go, wow, their central nervous system developed this entire efficient strategy around this dominant posture so that this person
Mm-hmm.
can continue in some way to care for their child, continue teaching and playing the violin and doing some things that were important to her. And the fear of the other stuff that was going on was limiting her variance of movement in and out of that dominant posture. So,
Yeah.
and she was very worried about how she looked, because she never really never looked in the mirror, at
Yeah.
her posture or anything before.
Yeah.
And when you go through these things, sometimes it's like looking at your face, you over scrutinize every little line and wrinkle
Mm-hmm.
and thing, and nobody else sees them.
Yeah.
So she was worried about that. She said, now I've got this big shift, and I'm sure it's not helping my pain and my belly and my pressure in my pelvic floor. It's like, well, before we even go there, I said,
Mm-hmm.
you're a performing artist, and you need certain aspects of this posture. That's
Yeah.
not going to change. This is
Right.
something that's kind of gotten hardwired in there, because this is your craft. I said, what I want to see is your ability to move in and out of that well.
Exactly. I was just going to say that. Exactly.
You
Because
know,
people can't move in and out of those postures well. They're
right.
they're stuck there, and whatever they do, that's where they're all their other activities of daily living. They're in the left, the left, the left, the left. And when they go to the right, they're like, oh, I feel off balance, and and that's just anybody. So it's very interesting. Very
Yes,
cool.
it is. It is very interesting. So we spent the next part of that just kind of working on, while you're just standing here, let's start doing some movement things. So rather than having her bend over and straighten up and go side to side, one of the things that was kind of I was thinking about early on as I was talking about, was the variance. And I wanted to see what happens if you stand on one leg. I wanted to start paying attention to her standing balance just a little bit, and see if I could get her to shift, and what she would do. Would she come out of that posture? Would she change? Show me what would happen. So, and I had her stand on her right leg first, because I knew she was going to stand on the left leg. She was already over there. And I didn't want to point out the obvious to her. I wanted to just have her, let me see what happens. And she was able to shift out of her posture somewhat, but she was unable to really hold the balance very well.
Wow.
Not more than about 5 or 6 or 7 seconds. This is a very
wow.
healthy 31-year-old female. So,
Wow.
she's able to stand on either leg very well, very easily.
Yeah.
And then when I had her stand on the left side, it actually took her even further to the left.
Yeah. Yeah.
So there we are, that left thing that you were talking about again.
Yeah.
And it was very interesting, because she would also, as she stood on the left side, not only would she continue to deviate further with her trunk or thorax, but she began to start rotating right.
Of course.
So it's like, okay, so she had to balance somewhere. So this is in that, kind of gets into the, and my baby's over here.
Yes, exactly.
On that side, my son is over here on this side. So the good news is that she had movement within that dominant posture.
Yes.
The challenge in front of her, and for me to help her with, was to be able to gain strength and confidence and coordination out of that dominant posture and over onto that right side somewhat, and to get some variance of movement in there. So guess what we started with? Let's do some, fingertips on the wall and some standing on the right side, and just see it. Tell me what happens under your foot. I just had her focus on her foot, not her body. Yeah. She was thinking about what was happening with her abdomen. It was like, let's just do this and get some shift and see how it makes everything feel. And so she concentrated on her foot, and she would say, I feel like I'm, standing more on the inside of my foot. And I said, well, then just do a little shift as she was holding onto the wall, and just see if you can get onto the, more in the middle of your foot or towards the outside. So she started kind of playing around with that, and everything up top was starting to change just a little bit. So it's amazing when you start getting them to move and focus on something different, that you can get them to pull out of some of those positions and patterns that they are really set up as a dominant thing.
And it's interesting, because a lot of times, we always see these shifts in patients, and, it's up to us to determine whether they're relevant or not. And I always find, especially in one of the patients I had treated, she was shifted to the left, rotated to the right, because she carried a lot of, she was a Broadway show actress, carried a lot of weight in the show. Her obliques, her whole abdomen was dysenergistic. There was no, it was an overabundance of recruitment going on, and I think that, if you look at people like that, especially someone like her, that's, if you actually get in there and feel around or start to recruit other muscle groups, you're going to find that, I'm sure you did, just really poor recruitment of certain
Oh yeah,
muscles
absolutely.
that work, right?
Yeah. So just to kind of paint the picture a little bit more, because, I obviously looked at her as I was doing a lot of this stuff. There was a definite underactivity of the gluteal muscles.
Yep.
A lot of people will call that gluteal amnesia. I don't believe that. I think
Oh, that's cool.
she was just in a position where they're not going to turn on.
Right.
She was in a position of, some lumbar extension and upper ab overactivity, kind of like that post-pregnancy. I still have a baby in there.
Yep.
And so the glutes were in a position where they weren't going to activate. And
Yep.
certainly that right glute wasn't going to activate with her standing way over on her left side.
No.
So it's, so just trying to, change and get her to change to see if some of that activity would come on. And again, she had a ton of breath holding going on with everything she did, which also told me that she was locking that diaphragm down to help her with some postural control, and really overusing that rectus muscle, just like you were talking about, just that crazy over recruitment, and not really allowing the other muscles to, get in and play around a little bit. So she had this, what I would kind of consider almost a global muscle strategy, which has been a good strategy. It's kept her upright and kept her doing, but she was using a lot of her global muscles in her abdominal wall. So the rectus abdominis, a lot of back erector spinae work, and not very much, glute work. So makes you wonder, the hamstrings working a little too hard. At that point, it didn't really matter. It just was more like, okay, we definitely have some discoordination going on through the entire trunk here, and we want to get that going. And so now she's armed now with the information that if we activate bring on some other muscles into the situation, that's going to help her DRA. Much more than trying to kind of pay attention to those muscles coming together in the front. I wanted her to understand the idea of tensioning. And one of the best tensioners of the abdominal wall is the glute muscles because of their pull on the thoracolumbar fascia.
Oh, interesting.
Oh, yeah. If you think about that, when we pull on that thoracolumbar fascia, that helps it tense up, which is going to give us some tensioning through that abdominal wall where the obliques, all come into that. And the transverses. So,
yes.
So I wanted to de-emphasize the abdomen a little bit, but I knew I could get the abdomen working by making her think about her hip muscles instead.
Going in the back door. Yeah, that's
exactly.
Great.
Exactly.
Love it. Yep.
Exactly. So we went through a few things like that, and I gave her some strategies in standing, to think about, kind of maybe leaning forward at her feet, being sure that she's breathing, so that, she could, I did a lot at her feet to change her movement strategies rather than telling her, drop your shoulders down, tighten up your belly, bring your head back up. All of that's too many. I just had her shift at her feet because she was starting to make changes there. And so she went home with three things. Number one, breathe. I had her breathe every time she moved so she could remember to breathe. So that was going to be her big mindful piece, was the breathing. The second thing is that I asked her, I said, when you are practicing, you don't have to do it while you're practicing, but every time you stop to turn the page or you take a break, I want you to just shift around on your feet. I don't care how you do it, just shift around.
Yep.
So I let her choose her own strategies. Let her figure it out. Let her central nervous system figure it out. I said, just shift around and feel what's going on your feet. Just kind of like, okay, I feel pressures here. I'm going to shift over here and feel them here for a little bit and shift over here. And I said, and then the third thing is that I want you to think about and, just kind of redraw your belly every morning and talk to yourself about what's normal and what's not normal so that you can remember the words that we, the stuff that we talked about. And then I sent her, a little narrative that she could, kind of begin to play with her, and I said, and I want you to, we're going to tell your husband what's going on now.
Yeah.
So she did. And so I got a chance to see her interact with her child and, do some of the bending and moving that she wasn't doing and some of the strategies that she was using, while she actually, I told her, I said, tell him what we talked about. So I could hear, what she, felt. And, she had a fairly decent grasp of it. And she was able to kind of, get out the words that, that I'm learning that what's happening with me isn't my organs going to come out. What I'm
Right.
learning is that I have muscles that are probably not working as well as they could, and we're going to start working on strategies to bring the whole system online. So some things like that. She had the basic pieces, and that's where she went away. I did see her for a number of visits because it took some time to get things going. As she came, one of the things that I noticed right off the bat with her as she came back in, the first few visits was changing, just automatically the changing of the dominance. She's always going to have a trunk that shifted to the left.
Yeah.
It's just going to be the way it is.
Yep.
As long as she's holding that violin, she's going to have a little bit of that. But what I started noticing is that she was moving in so many different ways, and so we were able to start getting right into going down into a squat and using the breath and and all of those things. And so she was learning some different strategies and feeling comfortable. But by the third visit, she wasn't holding her belly together anymore. Great. She had let go of that with her hand. She told me that she was going up and down the stairs with her son.
Oh, awesome.
And she was basically having him climb the stairs holding his hand, but whatever. She was going up and down stairs, so that was good. She wasn't carrying a whole lot up and down the stairs, but she was going up and down the stairs.
Going up and down,
so, yeah. I consider that a huge victory.
Totally.
And she said that she was sitting on the floor a lot more, which is something that she hadn't done very much of, because she didn't want to get on her hands and knees to get up.
Get up.
So as we move forward, you can imagine that the next thing we needed to do was we needed to tackle the fear of being where her belly could be, suspended, in a gravity dependent position.
Yeah.
Because there's many reasons to lean over a bed, lean over in the car, put the car seat, having to lean forward, those things. And so we started working, and it was scary for her in the beginning. So how I started her was on her side and got her to let her belly relax completely on her side. And I said, this is no different than being on your hands and knees, although you feel more supported. So let's work on, as you exhale, let out, just kind of bring all of the abdomen in, not just the front muscles. I wouldn't let her flex her trunk so she couldn't overuse her rectus. And, she just started recruiting one side, then we'd flip over to the other side, she'd recruit the other side. And, so she went home with that and practiced that, and it was safe for her. Yeah. Eventually we got her up onto her hands and knees and got her to, which was the hardest thing for her to do, was to allow her belly to completely relax down. Yeah. Now, culturally, that's a problem in the United States because people don't want to ever have their bellies hang out. Yeah. So we're facing culture and fear. Yeah. So, we're facing both of them. But she got to the point where she could actually let that happen, and then keeping her trunk straight on hands and knees, she was able to actually recruit her abdomen and bring it up without moving her trunk. So, I said, if you hump up, like the angry cat, I said, those are those big muscles in front doing the work. Right. They can work. We don't need to over recruit them. Let's recruit the lower ones, the deeper ones.
Right. So when you assessed her at the beginning, what I like about this is that you used a whole global strategy and you really changed how she moved, which is fabulous. Maybe you did, I don't know if you did, but you didn't. I think we're all taught, even in continuing ed, is to focus on, let's see how the transverse abdominis works. So let's see if you're activating overactivating your internal or external obliques. Let's see how multifidus is. And I don't, from my perspective, and you didn't really do that with her. Right.
Not in the first couple of visits. Right. And the reason that I did not go there with her was because she was hypervigilant about her anterior abdominal wall. Right. Yeah. And I wanted her to really, really understand that if we could bring on the musculoskeletal system and get things rolling and not pay so much attention to little bitty isolated things. Totally. Yep. That she could start making some good changes right away.
Yeah. But if you can change, like you did, if you can change her center of mass or get her moving over, these muscles could absolutely turn on without a doubt.
And we saw that, we saw First of all, I did it on purpose because I wanted to see if she could even just hold herself over there because, you know, again, I was talking a little bit of a risk of fall here of somebody who's holding themselves so rigid into one particular posture. But the second thing was what was going to switch on and what wasn't. And, you know, so she needed a little support with her hands on the wall to stand on her right leg. But I'll tell you, she started, you know, able to shift her weight and do things. You know, her central nervous system isn't, there's nothing wrong with it. It just wasn't asked to do anything different. And it just made that other, you know, it just made that other posture, it just made that very efficient for her because that's its job, right? You know, our central nervous system is supposed to make things as efficient as possible for us so we can remain cognitively active. Doesn't want us to have to think about what are we doing with movement.
Right.
We need to be thinking about what's coming.
Right, so some of the unloaded positions you started with were side lying with her and then on hands and knees.
Yeah.
Got it. Okay.
You know, and then she was able to begin to activate. And so the coolest thing about teaching people to get on their hands and knees, and I don't make them have a tabletop. I just, you know, there's a little lumbar lordosis maybe going on. I don't let them sag into full lumbar lordosis. So I want them to, you know, get a little oomph to the system there, but let that belly go so that, you know, that they can feel that those back muscles and glute muscles can hold them up just fine on their hands and knees. They don't need to have their abs overactive in that position. You know, those are the muscles that are really working at that point. And so, you know, so being able to really allow that belly to distend was a big step for her because she was still very afraid, you know, and she just, you know, was just really, it just took time. But once she realized that, you know, as she gathered it up, you know, and was able to lift without moving her back, so she was using strategies other than just her rectus, you know, is going, you know, brought everything in. You know, the coolest thing about all of this is that I never really had to go into and really work with the pelvic floor because her symptoms of heaviness were already decreasing as she was beginning to recruit and change other muscles. You know, so the pressures on the balloon were different.
Right.
She was beginning to mediate those pressures through her system just fine without having to go in there and, you know, put my fingers around and see what was going on. It's gonna see, because we had that symptom we could go with. Now, had the symptom not changed as quickly as it did, then I probably would have done, as a women's health physical therapist, I would have done an internal exam and just check to see how underactive are those muscles. Are they really switched off, or, you know, what's going on? But she was making the changes and doing the recruitment, and an external palpation, you know, could tell me that things were, you know, recruiting and firing up. I could, you know, get medial to the ischial tuberosity with her in standing or sitting as she was moving, and I could feel those muscles switch on.
Was she more afraid of the diastasis or the prolapse?
She was more afraid of the diastasis, but the prolapse was kind of like, you know, the next thing coming, like this was turning, you know, the iceberg was beginning to grow instead of melt. So, but the nice thing was that after about 3 or 4 visits, no more pain in her abdomen. And I don't really, it was interesting because the pain that she would talk about would be vague, but it would also be around her fear. When I feel like I'm straining, I hurt. And, you know, I feel like things are pushing out, you know, so it would always be in combination of those terms. So when she didn't feel like she was straining and doing all of these different movements, it wasn't an issue.
You know, it's interesting. I think that we have to, you know, like you did with the anatomy book, people who have these cognitive beliefs, like my back needs to get cracked, or I have bone on bone, which kills me. David Butler, when I took his course in Philadelphia in December, he called it the kisses of time, and I love that. But, you know, it's like you have to invalidate that belief from the get-go, and I know we've talked about this before, but because if you're not invalidating that belief or helping them understand a bit more why they should not be focusing so much on that, then whatever you do after that is not going to be as effective. And so it's worth spending the time educating the first visit or even 2 visits without even putting your hands on them, because a lot of that really goes a long way. And I think as therapists, we're so running around. We need to treat this. We need to put our hands. But with these types of patients, that's not going to be the game changer, right? So this is great. Love it.
So we started using her son in therapy as her resisted weights. So she started doing things like you would do with kettlebells, swinging her son up and down.
Aw.
And she laid on her back and, would raise her son up in the air and could see that, I just
Aw,
said,
that's
just add
great.
your breath in, so just blow out as you do it.
Mm-hmm.
Everything recruited beautifully. She wasn't doming anymore. And she was finally, beginning to spend more time, inside planks. I could get her to do
Mm.
that. The front plank took a while, but we got her
Yeah,
there finally.
that's
And,
great.
and then I told her, I said, find how many times a day that you actually can lean over and put one hand down to do something that you weren't doing before. Challenge yourself in that way at home. So she did. She was just like, she goes, even just like reaching over to make up the bed and reaching over to put pillows, she felt like she was like in that position, where her
Mm-hmm.
belly wasn't going to, things
Yeah.
were going to fall out. And, she moved his car seat to the middle of the car. Unbeknownst to me, she had it over on one side of the car because she wouldn't lean forward.
Oh boy.
So she was thrilled to have him in the middle of the seat.
Mm-hmm.
When her husband would come home, he would do it, but whenever she needed to go out with him, she had to have the car seat, on the left or the right side and not in the middle. So she was excited about that. These were all things that were important to her. So
Totally.
she was
Yeah.
able to, by the, so I saw her like for 4 or 5, I think 6 weeks in a row. She came in once a week and we worked on all these strategies and these things for her. And then after that, I said, go away for a couple of months. Let your
Mm-hmm.
body continue. And she did. And then, she would come back and we'd do some tune up and some changing and, talking and how about this and how about that. Well, when I do this and I do this, this bothers me or this or that. So we would go through a few things. It was mainly just, it made her feel better to have some eyes on her
Mm-hmm.
because she was still a little worried about
Yep.
stressing and stressing. I knew we were really on the right road when she told me, she goes, oh yeah, I carry the vacuum cleaner up and down the stairs. I don't even think about it.
Oh, that's
It's
great.
like,
That's
we're
good.
here, we're
Good
here.
to go. Yeah.
Then the next issue came up was I'm going to want to have another baby.
Yeah, I was just gonna ask that. Yeah.
Mm-hmm. And before, when I first saw her, one of her fears was that she would never have any more children because of all of this.
Mm.
So she goes, we're thinking about having another baby. And I said, that's fantastic. And she goes,
Mm-hmm.
and I really have the confidence that I think I want to go through and do this. And it's like, great. But in the meantime, she had a big violin solo coming up with the symphony. She's the concert master in the town above Pittsburgh at the symphony. And she was spending a lot more hours practicing. So we did some performing arts stuff. She brought in her violin.
Mm-hmm.
I looked at some of her movement with it and got her to begin to get some variance while she was practicing
Mm-hmm.
and playing and doing some things. And one of the things she talked about in retrospect, because now it's been a couple of years, and I'll give you the update here real quick, was one of the things she talked about. She goes, she goes, people have talked about how much more dynamic I am when I'm on stage.
Mm.
So
Okay.
she's very proud of that. She thinks her
Aw,
music has changed,
of
which
course.
gives me chills when I hear that,
Yeah.
because it's like your central nervous system just
It's a
became okay
beautiful
with
thing.
it. Yeah,
Yeah.
just it became okay with it, and it's allowing you some new outlets and creativity and movement and variance, which is just so
Mm-hmm.
cool. So
Great.
I've worked with her off and on over the last 3 years. I'm happy to say that she has her other son is over 4 years old, and her young son is almost 2 years old now.
Great.
She did not have a problem with her pregnancy. She came to me at various times during her pregnancy just to kind of, check in. Let's see how things are going. Let's see how things are doing, make sure that I'm staying on task with stuff. Never a problem though. And she really didn't have, after the pregnancy, she knew exactly how to take care of herself. I talked to her about, I think we talked about this the last time when we talked about pregnancy in one of the earlier podcasts. But postpartum, I talked to her about some perineal support with
Mm-hmm.
some nice compression underwear, to
Yeah.
give that tissue some support following the birth.
Mm-hmm.
And, that, and a light, easy, wrap over her belly just to support the tissues,
Yep.
because everything's kind of like whoosh, the balloon's been popped. And, for a little while until she felt, comfortable and confident. And she checked back in with me at 6 weeks after she saw the midwife. And we did do a pelvic floor exam to make sure,
Uh-huh.
everything was good and moving and not painful and, you know, all of the good stuff. And, you know, I just got her back into, I said, we took her down a couple of levels. I said, it's not a bad thing to go back down to, you know, recruiting those muscles on hands and knees again and on, you know, sideline and things like that, just to kind of remind the, you know, that everything, how it needs to do, and back over to kind of maybe you're standing on one leg, standing on the other, back to the squats, back to some of those different things. Yeah, your go-to things. And I said, you know, and, you know, just keep all of those moving. And when you feel strong enough, you know, you can just give me a call and we can go through some more stuff or come in or whatever. So the last email I got from her was last week, and she had she never thought she would ever be able to do this again. But she just completed her first 3-mile run in 6 hours.
Wow, that's amazing.
So she's out there running now. It's just so exciting.
It is. That's so cool. And she had no issues with the diastasis at all the second time? That's fabulous. You know, that's great. You know, you look at those stories and you're like, damn, it's just the whole, you know, from beginning to end, and how people say, you know, physical therapists and we're experts in movement, you know, but we're really, as well, we're strategists in a way, you know, just like financial people, like financial strategy. We're movement strategists. We can figure out ways to get you to move better, and we all do it differently, but the goal is the same, you know. And this is a beautiful story in that regard, because she had so many, you know, contributing factors, you know, emotionally and physically. So well done. Oh, awesome.
Yeah. So, and, you know, I know a lot of people will say, oh, well, you know, women's health physical therapists. And it's like, this is just a movement.
Totally.
Issue. It was a fear-based movement problem is what this was.
Yep.
You know, if you really had to diagnose it, like a PT diagnosis, it's, you know, it was just, you know, fear avoidance, you know, and once she, you know, and it was compounded, you know, by, you know, the fact that she had had a fracture and she had fallen, and, you know, and that she pictured herself so broken, you know, that, you know, that she just was not going to allow herself to come out of that. Yeah. Even though she wanted to, you know, the fear was holding her back so much. And
And it's not about, you know, specifically training certain muscle groups, because if you take twist out of someone's system, then the compensations really show up, and then you'll see what you have to train. And if you don't take that twist out or see how they move in and out of their respective movement patterns, you're going to miss something, you know. Just doing a straight manual muscle test, the way we all learn it way back in the day, just not going to cut it with somebody like this, I think. And it's really about just assessing someone, how they move and addressing those fears at the same time. So this is great.
Yep.
Very
and also
cool.
respecting their time. They don't have hours and hours. People don't have hours and hours to do side leg lifts and to do other things. But she could work into a one-legged stance kind of strategy training thing, you know, easily within her lifestyle. So I had to pick things that were going to work for her that also didn't scare the, you know, the crud out of her. So, you know, but it was, she's been such a joy to work with, and I couldn't be happier for her and her changes and the things that she's done. So,
great.
Yeah. It was fun to share that story. Yeah, absolutely. Awesome. Okay.
Well, thanks everybody. This was a fabulous case. I loved it.
This was fun to talk about, fun to think about. And we'll see you all next time on Tough to Treat.
Bye.